Hey guys, welcome to Stand By for Tones. My name is Isaac.
Hello, and I am Sam, as always.
Yeah, today we're doing something fun. So we are doing a little school project, and we are getting some education out for lots of providers.
Yeah, the whole goal behind this, it's kind of fun. One of the big things that I realized going back to school is that my life kind of had to be put on pause when it came down to recording lectures, all the fun things that we like to go and do for the community. But luckily, we have community service events that we have to do and service learning projects. So what we're going to be doing is giving back to the community. That is you guys in, the hospital, outside of the hospital, providing some free education and CEUs.
Yeah, so today we are talking about pediatric patients, and our whole lecture and everything is called Deceptively Stable. So we're talking about the reality of pediatric patients.
Yeah, so what we're going to be doing is what we like to do. As most of you know, we start off with a thesis statement. The big thing and the big theme of this one is kids aren't scary because they're fragile. They're scary because they compensate so well that we miss the moment they start to fail, which is oh so very true because we see these kids typically very late.
So some of the learning points we're going to go over today, we're going to do a couple different modules, a couple different sections. The first thing we're going to really get into is some pediatric physiology and why kids crash differently compared to adults. Then we're also going to be talking about pediatric trauma and pediatric medical, and then just kind of putting it all together from compensation to death. Yeah. So, and how we can avoid all of that. But the very first thing that we're really going to get into is kind of the social determinants of health, something that we've been going over in school, something that this whole project and learning project service, all this stuff is based on. So
one of the big things that we want to talk about in the social determinants of health is why kids terrify providers typically. So the pediatric calls feel very different. There's that weird feeling in the room. It's hard to communicate with kids. The parents are either very stoic or they're very frantic because they, don't understand what's going on. And sometimes, to be truthfully honest, we don't understand what's going on because we don't get that really good report that we would typically get from an adult patient. These are what I like to call halo events. They're high acuity, low occurrence events. So like we talked about earlier, we see these kids at their worst point, but we see them very infrequently, which adds to the stress of the typical provider. And that leads us to the fear of missing something early. Remember, these kids aren't scary because they're fragile. They're scary because they look okay until they don't. And we either get it to the very tail end of the look okay, and then they go to the they don't look good en route or at the hospital, or we get them at they don't look good at all situation. So let's talk about the social determinants of health and how it directly impacts the early recognition to our access to care and how it increases the risk of decompensation in these patients.
Yeah. So what are social determinants of health? Right. So these are going to be just kind of where kids are and where families are and kind of what determines how healthy people are and how healthy they can be. So some of the things that we have to look at are, the first one is economic stability. Obviously, this plays a huge role in healthcare and how healthy we are. If you don't have that economic stability, if you work in areas that are lower in, economic status, it's definitely a lot harder to be able to afford good healthcare, to be able to afford good stuff that keeps us healthy. Yeah.
Even if the want is there, the ability sometimes isn't there.
Yeah. I mean, I just picked up 2 bags of groceries from Walmart, and it was, I don't even want to know how much it was.
Yep. I don't even care to look at the bill anymore.
Right? Because, things are expensive. And it seems like it's only getting worse. So being able to buy good, healthy stuff for us to consume, it just gets more expensive. And I feel like the healthier something is for you, the more expensive it is compared to the easy access to process things that taste good.
Stouffer's mac and cheese.
Yeah, compared to making, actually a good healthy meal can be just expensive.
Yeah. Then we have education and health literacy, which is a really big one and kind of a heavy hitting one, because this really can rely on, generational education, background history, breaking of that. And, did we get that education that we need from an early age to learn to take care of ourselves, to learn and go into, the jobs that will help us promote economic stability and things like that. And then we have health literacy tagged onto that. Did we get the foundational information and the foundational training to know when our body's unhealthy, to know what some of these medical terms mean, and how do we treat some of the more common things like our common cold and things like that, that can, eventually down the line lead to ear infections and, progressively worsen to upper respiratory and sepsis. Like, it's just this whole really big chain link that health literacy plays into, and where can we break that chain to help promote the health of a growing child?
Yeah, and then talking about that health literacy, I mean, we think about us as providers, how hard it is going through school and learning all of these terms. And now these are things that they have to be taught to parents, and they have to be able to actually understand that kind of stuff. So, not taking their full course of antibiotics for their kids, things like that, not understanding what the label on the bottle means.
Yes.
All of that plays an important role, and it's something that we as providers have to push and make sure that these patients actually understand what they're supposed to be doing.
That's actually pronounced analgesic, not analgesic. Sir, the pills go in your mouth.
And then just health access. How hard is it to actually get health care? It depends again on where you're at on that economic stability as well. Where good health access and all that stuff, it gets expensive. Just for me, I know even just going to the doctor for my regular appointments, I get maybe one a year that is pretty much covered by insurance. But other than that, I'm going to be paying out of pocket for stuff.
$300.
Right? $300 right away. And then do I even have access to it, right? Do I live 2.5 hours away from a good hospital? Here, do I live, 2 hours from a level 2 pediatric trauma center, let alone 4 hours away from a level 1 pediatric trauma center? So a lot of these rural areas that we live in, that's a big thing right there, is living out in the boonies, which is great. I definitely prefer that compared to living in a city, but it kind of limits what kind of healthcare I'm actually able to access.
Yeah. Then we have neighborhood and built environment. And so this is, can play into rural and, our more, city-esque lifestyles. Is what kind of neighborhood do we live in? Do I live in, a little bit more low economic status neighborhood, and what surrounds that? And, it's really important to think about, the outside affecting factors that can contribute to this. So what is my living situation like, and what surrounds that? Am I surrounded by farm and beautiful, luscious green grass, or am I surrounded by factory with toxic chemicals and things like that? That true city life, rodents, pests, things like that can all play a huge co-founding factor in, treating and taking care of our patients. And, we have to remember that even in these rural areas, like, we're very blessed to live in a beautiful southern part of Idaho. But we also can't forget that, just a couple hours away, we have giant, chemical producing infrastructures and plants that make the nation's largest amounts of organophosphates. And then we have cow manure trucks and all these other things that can play into it. So it's not just limited to cities and, these other types of environments. It really hits the rural environments as well.
And for us, we're lucky, again, being in Idaho where we're at. It's, for as far as neighborhoods go, they're usually pretty nice, not too bad. I mean, you definitely get some of the more trailer park stuff, but you don't have big city where it's more ghetto kind of stuff. Like when I was in Atlanta, total culture shock for me. But seeing that kind of stuff definitely impacts what kind of patients we're going to see and what kind of risks it puts everybody at. So just, it's something that we don't always think about because it's a little different here, but it just depends on where you're at is going to change the likelihood of what kind of injuries and illness that patients are going to have. And then the last one we have is social and community health.
So yeah, the social and community health is a really big factor, especially in the more, I would say, in the elderly population, but plays a huge role in, really every population. But that social aspect of living, are you able to get outside and live your life a little bit? Do you have that feeling of purpose to go out and be with your friends, to be in your community center, to do the things that make you feel good inside? Because mental health plays a huge role in our, just overall general playing field of, medicine. And, do we have the community health that supports that? Do we have community, clinics? Do we have things that are going on like healthy cooking classes? Do I have opportunities to go play sports? Do my kids have opportunities to go and play in parks and be kids instead of sitting home and, seeing mom and dad for, a period of time, and then, just the whole round table side of things of the social community network is really big in promoting health, because we tend to talk to people about that. We talk about our health. We talk to families about struggles of raising kids. I talk about that frequently because, I'm in that really hard stage of the 5-year-old independence and how to get through that. And I wouldn't learn these things without my social and community health networks that I get to develop. And, it's a really big, proponent in maintaining these really healthy lifestyles that we try to do.
Yeah, and also we've seen that huge shift from kids being outside, running around, being healthy, to obviously now sitting in front of TVs or computers or sitting on devices. Yeah. And so you don't get that just good outside, get that good sunlight, sunshine, vitamin D, all of that kind of stuff. So that all plays a role in what's going to, I guess, happen to our patients and just what kind of patients we're going to see and some of the problems that it's going to cause later that we're going to have to deal with as healthcare providers.
And this really ties into why we're going to see kids arrive at hospitals or in ambulances or helicopters sicker, because the social determinants of health really kind of set this whole thing in motion. So we see our kids suffering from limited access to healthcare, especially in our rural communities, because we just don't have the pediatric capabilities, right? We don't have, like you talked about earlier, we don't have the ability to just, hop on a bus or get in a taxi or a cab and go to a level 1 trauma center or a pediatric specialty center. We have to drive hours or fly hours to get these things. And then one of the big ones that we see is the delayed recognition of caregivers. And that really comes down to our health literacy. It's not because they don't want to understand it. Maybe they weren't educated to understand when their child's getting sick. And that's where education comes into such a huge role as a caregiver in providing that, 5 minutes of your time to make sure that they understand, give them that teach back stuff, have them involved in their care. And then one of the other big ones, unfortunately, a lot of them come back to socioeconomic status, is transportation barriers. Can the parent get the kid to the doctor?
Yeah, and then we have, again, like we talked about, that socioeconomic stress. Again, just I know if I go to the hospital that it's going to cost me a whole bunch of money. So that makes it us want to not necessarily take these kids in to the hospital. I know my kid, I'm like, you're fine. Yes. All the time. I say that all the time.
Put a Band-Aid on it. I have a cold.
And my son likes to come up and I can't breathe. And yes, you can. You're fine. But that stuff absolutely plays a role in when we actually take our kids to the hospital. They've had that abdominal pain forever, and it's, you're fine. But, they have that ruptured appendix. Yeah. Or they have appendicitis, and then by the time we see them, it's actually ruptured, and they're way sicker than they are. It's just...
Or they just have to poop.
But this is just a really big contributing factor to why kids, they show up late and they crash so fast. It's not just because they crash fast, it's because they've been holding on for a long time already, and by the time that we get to see them, they're already very, very sick. So all of these social determinants of health just play a huge role in why we see kids just sick.
Yeah. And one of the big things that we try to preach, and, I'm really glad that our school is really good at providing a lot of the why behind things. I find that very good. But why does this clinically matter to us? As care providers, why does this matter in this situation? Because you're going to see kids late in disease process. They're going to have undiagnosed diabetes. They're going to have undiagnosed cancer processes. They're going to have, potentially undiagnosed cardiac issues if there's no prenatal care done beforehand. Because it doesn't just start with the kid. It starts with, the family in general of where we fall in that gamut of being able to get health care. And then we have, that we talked about a little bit, the delayed recognition by caregivers, and we see the compensation in progress. And a lot of that is because we just don't understand. We don't understand, and we underestimate the true severity of what's going on.
Yeah, you have to remember that you're seeing a lot of times these kids at their worst point, and even though they are still compensating by the time we get there, so they don't have those really late signs yet because they're really, really late signs, but they're on the edge of it. So it's something that we have to be ready for, and it's something, again, that we completely underestimate all the time. And we're going to get into all of this stuff and how we can recognize these signs and symptoms so that we don't delay care, that we recognize what's going on, we start that treatment fast, and we can escalate that process to, to doctors and everything else and get the point across to be like, hey, this kid's really sick. I know he looks okay, but we need to get going on him. And just having that understanding for us, especially as in EMS, you're the first line. You're the ones that have to recognize that stuff. You have to start those treatments. So we're going to get into all of that.
Yeah, so some of our big learning objectives, what we want you to take home. We're going to talk about the core truths next, which is kind of our golden rules. But our learning objectives, we're going to try and recognize early signs of pediatric decompensation. We're going to hit those pretty hard. We're going to differentiate some respiratory distress versus failure, identify compensated for decompensated shock, apply early interventions to prevent arrest, and understand the neonatal versus pediatric differences. And what we're going to do is we're just going to bring a little NRP in. NRP is a pretty, big side quest into this. So we're going to tie it into a little bit of it. I do love NRP. It's one of the best classes you can take if you're going to be taking care of kids. But, we're going to try and tie that in a little bit into this course.
Yeah, so those core truths, right? Pediatric arrest is usually respiratory first. I know you guys have heard this. It should have been hounded into any care provider, but it's something that we reiterate, and it's the reason that it is so pounded is because it is true. Pediatric arrest is respiratory first, almost always.
Yeah.
Okay. Our trauma and medical patients, they actually do fail in very similar ways. Obviously, trauma and medical are different, but the whole failure cascade and how kids go into arrest, it's the same thing. It's a respiratory failure, it's hypoxia, acidosis, and then it's bradycardia, then it's those cardiac symptoms, and then it's that cardiac arrest. Whether it's, again, it is trauma or medical, they do fail in similar ways. One of the big things as well is hypoxia. Hypoxia is the enemy. Back to, again, respiratory, but hypoxia kills. And it's something that kids compensate for pretty good until they don't. But we have to recognize hypoxia early in our patients. No matter what the cause is, we need to recognize the signs and symptoms of hypoxia because it's not always that they're blue in color. Right? That's what we think of when we think of hypoxic, but that's a late sign, folks. That's late. So, and then the last thing is, again, bradycardia in kids. It is an oxygen problem until proven otherwise. If we're seeing bradycardia, we're way behind the 8 ball.
Yes.
We need to oxygenate quickly.
So where this leads down to is what is going to impact our kids the most, and threw together a little kind of triangle of criticalness is what we'll call it today. Is, as you can see there, that cardiac arrest is that epicenter of the badness that we want to avoid. Hypoxia at the top, bradycardia and acidosis at the bottom. if we can prevent hypoxia, we can prevent that acidotic environment, preventing that bradycardia, ultimately surrounding that cardiac arrest in the center there. So we really, take a page out of the PAT, the pediatric assessment triangle, and, really use that deductive reasoning. Do I have hypoxia? Is that going to lead to acidosis? 99% of the time, yes. And what's going to happen after that? It's going to be bradycardia and arrest faster than you think. So make sure you have that triangle of doom kind of in your brain when you're seeing these pediatric patients, whether it's inside, outside, or at home, when you're dealing with pediatric patients.
Yeah. So, and we talked about, again, trauma and medical. We're going to get into all of this and just how they have that similar ending that we're all trying to avoid. But let's get into this and let's start talking about some pediatric physiology.
Yeah, so the pediatric physiology is super fun. I really like pediatric physiology because they are so different. And one of their big key differences are, and we're going to talk a lot about this, one of the big ones is the high metabolic demand that pediatric patients have. They have a higher oxygen consumption per kilogram of body weight. So they need more oxygen. They need to stay higher for longer periods of time. What does that lead to if you don't? Acidosis, bradycardia, arrest. They have a faster baseline respiratory rate because they don't have some of these key the compensation mechanisms that we would think of as adults, and they have a far less tolerance for interruption in these. When that comes down to it, is you interrupt one of those triangle of doom sections, you're going to lead down a pathway into that, cardiac arrest triangle that we talked about.
And talking about higher metabolic demand, I'm going to go a little bit advanced here for all my more basic providers, but anytime I put somebody on a ventilator, the whole reason, the way I come up with how I'm going to set my vent settings is based on what is that patient's metabolic demand right now. Did they just hit their head and their metabolic demand is pretty normal and we just need to protect the airway, so it's going to be a normal type setting? Or is it somebody, I'm talking to adults here, who's really sick, septic, on multiple pressors, so they have a much higher metabolic demand or oxygen demand? Well, kids are the same way. When we put pediatrics on ventilators, we're typically double what we are for adults as far as metabolic demand and minute volume, just because, again, they have that high metabolic demand. So that's something that we need to understand that, and for us, metabolic demand, just think oxygen consumption for these patients.
That was good. I like that because I'm really glad you brought that into, because one of the big things that, you said it, I wanted to say it, and you said it better than I could have, is even the standard pediatric patient that we put on a ventilator, I'm starting them at a higher minute ventilation just based off of their increased metabolic demand of being little and younger. So, you have to keep these things in the back of your mind of why they compensate and then they don't. And so where that takes us to is our low physiologic reserve. So they have a high metabolic demand. They have a smaller functional residual capacity. Remember what that is that, after exhalation, kind of that residual volume that hangs out in your lungs and provides oxygenation. That is weight-based. And so we need to make sure that we understand that if they are going to stop breathing or they are hypoxic, that we need to oxygenate better and longer than we typically would in an adult.
Yeah, they also have less cardiac reserve. Remember that we're going to get into this. These kids, they compensate differently. Adults, we vasocompress pretty dang well. We can move that blood volume away from our extremities, away from everything else, and bring it back to our core. Kids are not the same way. They are going to rely on heart rate. So they have that less cardiac reserve. They have less room for blood loss. Again, adults, we have a lot more blood volume. Kids have a lot less blood volume because, again, they're just smaller, but a lot less cardiac reserve. So that's something that we need to pay attention to when it comes to heart rates and blood loss for sure, and making sure that we are keeping these kids tanked up.
Yeah, and with that, with this loss of low physiologic reserve, they have that immature sympathetic response system. So we typically think their heart rate compensates, which is very true. We're going to talk about that pretty in depth, but they have a very weak and immature sympathetic response. So they don't have that vasoconstriction and dilatory effect that we as adults typically do when we start to get sick. They just don't have that compensation system. So that's something that is a major key player in those instances when these kids show up sicker than crap.
Yep. And that leads perfect into, again, just compensation over collapse. Remember that how we maintain our blood pressure and feeling good is cardiac output. Cardiac output is how much blood volume is going to be circulating through our body every minute. And that's controlled by two things, stroke volume and heart rate. So stroke volume is how much blood's actually being pumped out of the heart. And then you times that by heart rate, and that gives you your cardiac output. Kids, like we just talked about, they don't have that ability to really vasoconstrict like adults do. So they have to compensate with heart rate. Kids also are great because they have really good hearts. If you think about the heart as a rubber band right now, if you think about that, kids, think about a new rubber band that you get out. It's nice and stretchy. It goes back, snaps right back. All right, you can snap your friend with it. It hurts compared to an old rubber band that gets a little less
elastic.
Yeah, it loses that elasticity. All right, it stretches out. It doesn't snap all the way back. All right, it eventually becomes brittle. And again, it just doesn't work as well. Kids have that really good rubber band. So when their heart fills with blood, it fills up and it pumps it out. So they have good stroke volume. And they are able to maintain good stroke volume with high heart rates compared to adults. We don't have that as well. For me, I think if I walk up the stairs too fast and my heart rate goes to 130, I'm ready to die, right? Where kids can typically, they'll compensate, and you're going to see heart rates of 130 all day long. You're going to see heart rates of potentially 180, 190, even 200. A good rule of thumb that we've talked about before and that I always think about is 220 minus your age.
Yep.
So if you're 1 year old and you have 200 heart rate, that adds up to 201. That's within what we would consider a normal limit without being a actual cardiac dysrhythmia. For adults, somebody who's 70 years old, right? I mean, if they have a heart rate of 150, that's way too fast for them.
Yeah.
And that's probably above the range of what their heart can actually get to without being in some sort of dysrhythmia. But biggest thing, get back to this, is kids compensate with heart rate. They can move that heart rate up and it can stay there for a while and they can maintain that cardiac output for a pretty long time. But remember, they just don't have that other compensation to help with that cardiac output, that stroke volume and everything else. So.
Yeah, and then some of the other things that we really need to look into is we talk about pediatrics being respiratory driven, airway first, you can have nightmares of it like it's boot camp, right? Tachypnea maintains our oxygenation in kids. That is the first major sign. This is an early key indicator that something is going wrong. If your kid is just sitting there and they're breathing, at 40 or 50 times a minute, and they're not supposed to be for their age range, then you need to think that something's wrong. You're leading yourself down a path where they could start losing their oxygen status, and they're going to decompensate fairly quickly, which leads us down that similar pathway of airway acidosis, bradycardia, arrest. And you're going to see a common theme of that here because we're going to talk about blood pressure next and why, and it drops late because, we compensate. These kids compensate so well that it just, it stays up a little bit longer. And, when these kids lose what little physiologic reserves they have, that blood pressure drops, and that's going to be a fairly late sign that it's really hitting the fan in these pediatric patients.
Yeah, and something that we don't get a lot on patients, pediatric patients, that is blood pressures.
Yeah.
I mean, I can remember even being taught that we don't get blood pressures on kids at some point in my career. I know that.
Estimate it. Yeah.
Yeah.
Yeah. They're this old and they're pink. They have a good blood pressure. That's not so much true.
Yeah. Get those blood pressures. I know it's harder, but we need to get those BPs on them and understand where they're at, where they're compensating, if that's starting to drop, because again, late blood pressure drop is a late sign. So, a couple things to remember on how to understand if it's actually good blood pressure or not, because again, kids' blood pressures are usually a lot lower.
Yep.
So a lot of times we get that blood pressure and it's like, ooh, I don't even know if that's good or not. Even myself, I have to think every time I get a blood pressure on a kid, I have to go back to my calculation, which is age in years plus 70 is that minimum systolic blood pressure that they have. Age in years plus 90 is typically normal blood pressure. So I look at those two things. If it's below the 90, okay, then I'm looking at that 70 range. Age plus 70, what is it? Okay, wow, we're
getting close.
We're getting close, or hey, we're way off here. We need to fix something. So just good little numbers to remember. Age plus 90 is normal range. Age plus 70, that's our minimum systolic blood pressure that these kids are going to be able to maintain to actually, again, have a perfusion for the rest of their organs. So we're not getting into that acidosis, bradycardia, all that stuff. But age plus 70 and age plus 90. Remember those things.
Yeah, so one of the things that I just swapped around because it kind of, clicked in my head here for a second is we're going to go into neuroprotection at a cost really quick, because with all of these compensation things, we're going to talk about why things change differently and how they change faster. So I wanted to throw neuroprotection at a cost up one slide spot, because these kids, they're going to prioritize in their physiologic changes one very simple thing. They are protecting the perfusion of their brain and oxygenating their core organs, their heart, their lungs, their kidneys, the best that they can. But they're going to start teetering off fairly quickly. So we need to remember that these kids use these protective mechanisms to really protect their brain, which is incredible because, we see a lot in adults where, that can be kind of a secondary compensation depending on what's going on. And got to remember that this is going to preserve consciousness fairly good, but temporarily, because these kids, they are so oxygen and cardiac output driven that once they reach that level of I'm going to fall off the cliff, as everybody has heard before, they're going to do it very rapidly. And this is where the kid looks okay while the physiology is working overtime. So you get to the bedside, in hospital, out of hospital, wherever you're working, you see them and you're like, okay, you get a little breath of fresh air. You're, okay, we can turn this around, but if we don't act just fast enough, that's when that physiology runs out of working overtime and they crash quickly.
Coming to mental status here, again, we normally see adults. When we think about mental status changes for adults, we think of that they're completely altered, right? If we have a kid that's altered, that's insanely late sign. So for mental status changes, it happens early, but it's not that they're unconscious or altered. It's just think about their behavior. Behavior should be a vital sign for your pediatric patients, right? Kids that, when I walk into a room and I see a kid who doesn't want to see me and is holding on to mom or is crying or is upset, I love it. My favorite patient right there.
Yeah.
Because we're doing okay. Kids who don't care, obviously, we're worried about that. When it comes to babies, we have to think they're going to start to get fussy, right? That is a behavior change. That is a mental status change for that kid. If the kid is fussy when he's normally not, that is an early sign for us to say something's wrong, right? Hopefully parents recognize that, but for us as providers, that's what we have to recognize. And you have to even ask that question. Are they normally this fussy all the time?
Yeah.
Or is this completely new? So think of behavior change as a vital sign.
And that comes down to sorry to jump here for a second. The big thing, just think about going back to your charting software. Doesn't matter what it is, Epic, EMS charts, Image Trend. If you go and you change the patient's age to something less than, 10 years old, somebody that's, a little bit more mentally immature, their GCS scale changes in their charting software. It goes from eyes, verbal, motor to, are they cooing and babbling normal, or are they crying unconsolably type situation? And that is right there where we need to tie into why is the GCS scale changing, because it is a vital sign, right? And that's where this big behavior change comes into, is you need to, kind of connect these dots a little bit of why are we looking at this as a vital sign now? Because it truly is, because kids change their mentality around how they feel. Like, I know I do. I'm a giant kid at heart, but when my daughter gets sick, I know very quickly when she's not feeling good.
Yeah, it's an early sign. It's an early vital sign. Irritability, all of a sudden. If we're talking young school age kids, they get cranky quick, and that's just them starting that to be sick, right? They're starting to have some change in their metabolic needs, that irritability, and then that moves to lethargy, and then pretty soon it's just decreased interaction. And then the worst of all is you walk in and you have the quiet kid.
Yeah.
And the kid who doesn't care. That
terrifying.
Is, for me, yes, 100%. I'm like, crap. Well, we're way behind the ball here.
Yeah.
So remember that just behavior change is a vital sign, and pay attention to that.
I know we've preached this time and time again, the respiratory driven arrest. But one of the big key things that we want to take home, and we're going to round this all back together, I promise, is if you fix oxygenation early, you're going to be a step ahead in the game. We can start preventing our arrest situations if we can continually, follow our assessment triangles. And if we fix that oxygenation early, we're going to start altering acidosis. Remember, if we have end-tidal CO2 hooked up, we can alter acidosis based off of our end-tidal CO2, improving their acid-base balance, which is pretty incredible. And you got to remember that these always start with airway breathing, because these are airway-driven arrests. What's our first thing we do in NRP when we get to a patient? We do suctioning. We do Mr. SOPA. We do mask adjustment. We do repositioning, oxygen, pressure, all of the fun things that we need to do to predominantly fix the respiratory issue that's going on. Because typically these are not a primary cardiac failure patient.
All right. So with all this physiology, the big thing that we need to pay attention to is the big lie out there, which is their vitals look okay. Remember, this is not the adult patient. This is the pediatric patient. So what can look like normal vital signs, if we are not paying attention, we can think that they look okay. But if we're paying attention to all of the stuff that we just talked about, looking at that mental status, behavior, what their actual heart rate is, even though it's up a little bit, but their blood pressure is fine, their oxygenation, they're still 99%. They're doing okay. That is the big lie. That is something that we have to really pay attention to and really focus in, and do good assessments will help us understand that this kid is already compensated. He's already in compensated shock, and we need to really prevent that from going any further. So let's start these interventions.
Yeah, and where that really comes into, the vital signs look okay. That big lie is they're okay until they suddenly are catastrophically horrible. And that's an awful feeling to be in. As, new nurses, new paramedics, new physicians, they all get caught in this, where we are, treating numbers and not our trends. So we got to remember, we need to treat our trending vital signs, because a heart rate increase from 150 to 160 may not sound like a lot, but if it's trending over time, those are big key indicators that our patient's not getting better. They're getting worse. And when is that patient going to decompensate? And then we always have to remember that it's not just respiratory rate that we look at as a vital sign. It's their effort. Do they have those intercostal retractions? Do they have those subclavicular or supraclavicular tracheal tugging retractions? Because those are huge indicators that we look at, because, we could have tracheal tugging and a normal respiratory rate depending on their stage of decompensation. we have to look at this through a broader picture instead of focusing on, the penny that you're an inch away from, if that makes any sense at all.
Yeah. Another one is grunting.
Yeah.
When I hear grunting, it's just like seeing a kid who doesn't care. To me, that's
one
a
of my
concern.
big things is uncontrollable drooling. Like I get in there and this kid's just laying in a puddle of drool. Is this, croup or epiglottitis? Which pathway am I going to go down to? So you have to really look into these things.
Talking about their appearance, let's get into this pediatric assessment triangle. Let's just go into our 10-second deterioration predictor, and let's look at this triangle and what these kids look like. Go ahead.
So the 10-second deterioration predictor, the PAT, is a very nationally recognized assessment tool. And we really think of this as our doorway assessment tool, okay? This is what you're going to assess as you're walking up, either in the hospital, outside of the hospital. And the three things that it's going to base off of are appearance, circulation, and our work of breathing, because these are all very visible signs that we get to see as we're walking up to our patient. So when you look at them, what's their tone like? Are they moving around? Are they interacting or not? Are they consolable in any form? If not, it's a sick patient. What's their circulation look like? What's their skin color? What's their heart rate? What's their capillary refill? Capillary refill is a great indicator. I know a lot of the times people say, oh, capillary refill is BS and it's not, a good indicator, when truly it can be a great indicator of how our perfusion status is. If there's something wrong, we're going to assume that kid's sick. And then work of breathing. What's our respiratory effort? Is it fast? Is it slow? What are their sounds? Are they grunting? Are they gurgling? Are they coughing like a seal? Are they high-pitched inspiratory stridor? And what is their position? Do they have retractions? Any of those are abnormal, we go ahead and we consider them a sick patient. And we go through this every time we do an assessment. Is it getting better with our reassessments?
Yeah, another thing I'll add on the capillary refill, which can be, again, very, very good. We think when you do that cap refill, it should be normal. Take about 2 seconds, especially for kids, for that blood to come back. One thing that we can easily miss is when you do cap refill on a kid and it snaps back like instantly, that's not necessarily a good thing. That means that they're compensating right now. They have that high heart rate. They're moving blood because, again, they're compensating. So when you have that super, super fast cap refill, ultra snappy, that's actually a sign that they're sick.
So let's talk about pediatric trauma here. And some of the things that we typically see is anatomy makes pediatric patients really hard. And that comes down to a couple things. One of them being is kids have a big head. And those heads like to flop everywhere. And the anatomy inside of the head, although there's good and bad with it, can make or break how you're going to treat this patient. Yes, they have a good size cranial vault and a smaller size brain, so brain bleeding and neurologic changes are a little bit different in these kids. But at the same time, it leads to things like internal decapitation. It leads to airway obstruction, all sorts of things that it comes down to with just having an oversized melon.
Yeah, oversized melon, big tongue, making that airway obstruction a heck of a lot easier to happen, something that we have to pay attention to when we are providing respirations for these kids. Remember, you're going to be potentially adding some padding to their shoulders to keep their C-spine in line, to assist with those ventilations. One of the hardest skills out there is actually doing a BVM on a child.
Oh, yeah.
Especially little guys like under 1 year old, even 2, I would say. I can think of a few times where having to ventilate a pediatric patient's taken 3 providers. It's taken one person to hold the mask on their face, one person to squeeze the bag, one person holding their head and shoulders just right until we can get some more hands to get some padding and do some stuff, because, again, it's just one of the hardest skills that we actually do. It's actually easier to intubate these kids than to actually use a BVM on them. So for all my basic providers and everyone else, something that you're going to have to work hard at and make sure that you're doing right, because it actually is pretty hard to ventilate pediatric patients with a BVM.
Yeah, I'm really glad you brought that up, because that leads us into, a little bit of resource, just tail on to that, because, you were talking about having 3 providers to BVM 1 patient.
Yeah.
Where's the rest of you don't have any more resources. What are you going to do? You don't have somebody to drive for you, or you don't have, another, if you're in a rural hospital, you don't have another set of hands. So preparation is really big in these too. So if you're going to a kid, make sure that you take your towel roll, or use your pediatric backboard that has a little air cuff on the inside of it, so it can align their shoulders and things like that with you. But with that, the anatomy that also makes it work is their weak neck. They have a hard time holding up their heads, especially when they get sick and they get tired. They're going to do the head bobbing. And then what does that do? That leads to airway obstruction. So we need to support these kids' necks to help them, just have that fighting chance at a physiologic reserve in being able to maintain while we are playing catch up.
Yeah, and another anatomy change, or something that's different with kids as well, is we can think about their ribs. They have much more flexible ribs, much more flexible bones all in general.
Yes.
But with ribs, not as much protection. So we have definitely potential for a lot more internal injuries to happen, which is why trauma is such a big deal with kids. But yeah, it's just something to think about as well. Is those flexible ribs.
Yeah, and that's going to lead us down to where we're getting into pediatric trauma is really deceptive, because a small mechanism does not always equal a small injury. Because you think about these pediatric physiologic changes, just like the small ribs, it does not cover the entirety of the liver like in most adults, right? You see these kids with, small or high-grade liver lax, and that can hide really, really well. They have a little bit more flexibility in some of these places that it can go. And they also have a reduced circulating volume. So they lose, a large amount, what would be considered a large amount for them, but you're not going to see it as early in some of these things like ultrasound, CT scans, and you're not going to be able to see that big distended belly like you would in an adult patient. They're going to say, my tummy hurts. And that's about it.
Yeah, and I think of pediatric patients just like I think of really old geriatric patients as well, where it doesn't take the mechanism to cause some of the major injuries.
Yeah.
Some of the things that a small little fall for an older adult can be completely detrimental. It's the same thing for kids. So kids are a little more bouncy, which sometimes is definitely nice and definitely helps them out.
Yeah.
But just again, because there's a small mechanism doesn't mean that it is a small injury, and we need to really pay attention to that. And we're going to go back to that first part of the lecture where, again, looking at all of those different vital signs, and don't be deceived that they are compensating at the moment. Pay attention to what's going to happen and think ahead.
Yeah, and so what we've kind of talked about already is hemorrhage is hidden and can kill really fast in these pediatric trauma patients. Remember, they have that small circulating volume. They compensate for shock really well until they don't, and then they crash really, 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 really fast. And that's where our early interventions really need to come into place. And some of those big interventions that we're going to talk about are things like IV and IO and blood, and how important it is.
Yes, IV access and interventions like that are definitely important, and it's something that is hard for everyone to do. I heard it talk about just the other day in class where fellow nursing students were talking about freaking out about how they don't think they could start an IV on a kid, and that's students, but it happens to providers as well.
Yeah, it's very normal.
It's very normal, and it's definitely harder to get IV access on kids, and there's always the fear of IO access. IO access is very important. It's something that works amazing, but it's hard to put a needle into somebody's bone and not feel bad about it or be worried about that. So it's one of those things that we have to overcome with our treatments, is being able to actually do what needs to be done. The kid is not going to like an IV, 100%. I get it. Started a lot of them on kids. They don't like it, and I don't blame them, but it's something that you have to do. It's something that you just have to get over. and get over that fear and just do it. All right. There's plenty of times, even myself, again, still question like, do we really need an IV? Do I need to go through that? Yes, you do. Just get it done. Get that IV in. And just remember that that's just another step in breaking that whole chain of how these kids can decompensate. So get that IV in and get it done as quick as you can and just do it right.
Yeah, and it really ties into what we talked about of that provider fear in that beginning. And I think you hit that great. And I'll just kind of put a little story to this because, it's not fun to do these procedures on kids, but it's an evil necessity, right? We have to take care of these kids. And so I had a kiddo that was very ill. We got called for a seemingly benign situation. We're going to get there, take care of the kid. And that's one of the other things too, is never believe dispatch when it comes down to the illness severity of what you're walking into, please, for you EMS providers. We get to this kid that had a medical procedure done and was having what was kind of described as light bleeding. And I walk into the back of an ambulance to find a completely floppy kid who is bradycardic, who is barely breathing, who is mottled, but still has an audible. I could auscultate a heart tone, and I could feel very weak central pulses. I gave myself one shot, and usually I give myself 3 of getting an IV on a kid. I gave myself one shot at an IV and had to go straight to IO. Yes, it sucks, but at the same time, this is a life or death situation of breaking that chain of survival early, or breaking that chain of death, I guess I should say, very early. Because if we would have waited around and messed around for an IV for 5-10 minutes, this could have been a completely different story. Could have been in a cardiac arrest situation, full trauma resuscitation, where we pulled the trigger on the IO literally, and we were able to get access, get blood on board, get hemodynamically stable, and have a crying infant when we arrived at the hospital. Like, it's just one of those things. Did I feel good about doing it? No, absolutely not. But did I do it for the betterment of my patient population? Absolutely. So you have to learn to overcome some of these things. And even after 16 years, I still feel bad about doing some of these things.
Yeah. And something that we have to remember and realize is just because they're a baby, they're a little guy, it doesn't mean they're a porcelain doll.
Yeah.
Right. Even simple things like suctioning an airway. We'll talk about RSV and some other stuff, probably, some of the medical problems that we can have. But when we suction these kids out, for me, I know it's hard to actually get in there and suction them out.
Yeah.
But then I watch some of my coworkers and that are specialty for pediatrics and stuff like that. And I watch them do it. And these respiratory therapists, when they go in and suction a kid, I'm like, oh my gosh, we're so mean.
Yeah.
Like, how do you do that? But it's very important to do. It is okay to actually suction the kid's nose out and hold their head still so they can't flop around. And yeah, they're not going to like it, but
let them cry and scream.
They can cry and scream, and guess what? They can breathe a heck of a lot easier, and it's really important. So we have to do these interventions. I know it's scary, but again, they're not porcelain dolls. I know they're fragile, but they can take a lot, and we have to get these things done to start actually treating our patients and moving in the right direction. So,
and one of the things that I kind of hold near and dear to my heart, and it's just one of those things that as a parent that I have to remember, is that in these younger populations, the likelihood of them remembering you sticking a suction catheter in their nose at that time, they're not going to remember that. I'm going to remember it. I'm going to remember some of those things, but that kid is going to go bebopping through life because you intervened early, not even flinching or remembering at that most of the time.
Yeah. One thing I do remember is an IV as a kid. And I remember being freaked out. I don't know how old I was, but I know I was freaked out because they had to start an IV. And the nurse that did it, I was sitting there yelling, I don't want to, I'm freaking out. He counted down from 10. By the time he got done from 10, I was expecting him to actually poke me. It was already done.
Yeah.
I didn't even feel it. It was done. I had an IV, And ever since then, I would literally be like, oh, cool. As a kid, hey, like somebody had to start an IV on me. I was like, oh, cool. Like, and then I would watch it and I actually didn't mind it at all.
Yeah.
Even to this day, I could care less about an IV.
Yeah.
Like, you want to start an IV? Sure, go for it. You know,
Yep.
Don't pop a zit, wife. But I'd rather have an IV than my wife pop a zit on my head or my back. But
hurts so bad.
it's the worst. But anyway, no, kids do understand it. Don't lie to them about it, especially when you start getting into a little bit older. So another really good story I had was a 4-year-old fell second story window, broke his femur. But he was with it and just telling him exactly what I'm going to do. And he was hilarious because he was just like, are you going to give me a shot? And it's like, yeah, I'm going to give you a shot. Okay. And then one of the questions he asked is like, are you going to shock me? Like, oh man, you watch too much TV, you little bud. Like, I'm going to put you on my monitor, but it's not going to shock you. Yep. So you be honest with these guys, understand, again, the older they get in kids, the more we need to tell them exactly what's going to do. Don't lie to them. Don't break that trust, but we have to get that stuff done. And again, it's part of what we are there to do. So you got to get over that fear and you got to get it done.
Yeah. And please don't lie to them. If you know something's going to hurt, tell them it's going to hurt.
Yeah.
Okay. It's going to ease their emotions quite a bit, because most of the time what you say is going to hurt a lot less to them, what they're, perceiving it as. So try not to lie to your patients, please. And that's going to bring us in kind of the last little section of, where we're wrapping this up into in the trauma section is that trauma failure pattern that we talked about. Where we add a little key step into this is that initial injury. We can't take that back. That's a primary injury pattern. But what we can fix is that hypoxia, acidosis, bradycardia chain of doom. And, there's going to be other things. There's going to be blood control loss. There's going to be, fluid replacement and things like that. But if we treat the core 3, we're really going to be in a good spot as, medical professionals in general. So just really try to bring home that core 3 the best that you can.
We didn't talk about slide 30.
I skipped a slide, didn't I?
Yeah.
Okay, let me go back. Okay, so we just finished up talking about
we talked about, remember, the suctioning and the IV.
Okay.
So along with suctioning and all that.
Along with suctioning and all that. Okay, so one of the big things we talked about airway and breathing, it kills just as fast as blood loss and things like that. It's our primary indicator. But remember, there's more than just respiratory obstruction. There's more than just respiratory disease. We have to remember things like pulmonary contusions, atelectasis. With big things like pulmonary contusions, they get delayed failure because they have that initial injury, they're breathing okay, then that bruising and that, adhesion-y side of things starts to take place. They can get a little bit of trapped blood, or just depending on what kind of chest wall trauma they have, they're going to lead into more of a delayed failure. So you really need to reassess these chest wall injuries frequently, because if we don't get that tension pneumothorax, that evolves rapidly. And remember, we talk about this quite a bit in some of the other stuff that we do, is positive pressure ventilation with 3 breaths takes a simple pneumothorax into a tension, and then they're getting a needle in their chest or a finger in their chest to relieve that tension pneumothorax, because these things just happen so quickly. And that's why we're trying to harp on these airway breathing, treat the underlying cause and act early side of things of this lecture, because we really want this to be driven home, and especially with that reassess frequently, because without frequent reassessment, we miss things.
Yeah. And tension pneumothorax, again, we don't see those as much in kids. One thing I'm going to talk to my advanced providers about right here is your intubations. Remember that it is very easy to main stem pediatric patients when you do your intubation. And it's actually quite a bit easier to left main to a pediatric patient than it is an adult. So that's stuff that we have to pay attention to. We have to know and watch that frequently, especially because taping a tube down and getting that secured can be difficult in your pediatric patients. But just remember that if we are going into either right or left main stem, we're going to cause atelectasis really, really quick in these kids if we don't cause overpressure ventilation injuries because we're only ventilating one lung. So chances of pneumos and stuff like that can definitely happen a lot quicker, but just something to pay attention to and think about when you do that advanced skill. If you have to intubate a kid, is making sure that we are not main stemming those patients. With adults, I mean, we're used to shoving that tube way down there. So, and if we main stem them, it's okay. We pull it back and we continue on. With kids, it's a little bit more difficult. So just pay attention to that kind of stuff and reassess frequently. Make sure that tube has not moved.
And where this is leading to is to round out our trauma side of things. Is we add one thing to the trauma or the triangle of doom, as I've been calling it. Is we add that injury pattern. So make sure to remember your basic trauma care. Stop the bleeding, replace the blood products, get your fluid administration going. Don't over dilute them. We need hemoglobin. Don't forget about that very important thing. Hemoglobin's very important. But if we can break this, the chain of doom of hypoxia, acidosis, bradycardia, we're getting to a point where we're in a good spot. We can, start to get down into fixing that underlying cause, and we're not in so much damage control at that point. So really, really work on identifying okay, we have an injury. We also need to protect airway, breathing, circulation, because we want to keep them out of hypoxia, acidosis, bradycardia. Those are your reasons why we are here today to talk about these pediatric patients, is to raise awareness to the things that we all know, but, we get tunnel visioned into some things.
I'm just going to finish off on trauma with fluids. Yeah. So I know you talked a little bit right there about, we don't want to turn them into Kool-Aid, but we need to realize how much fluid we're giving them.
Yes.
Pay attention to their weight based in kilograms. Make sure you're doing your only 20 mLs per kilo for your boluses, 10 to 20, probably 20 on these kids. But fluids, just like ventilation and everything else, can run away from you really quick. And again, they have a small tank, so we need to make sure that we're paying attention to how much fluid we're giving them, and reassessing same thing, that kind of stuff frequently, to see where we're at. So pay attention to your fluids when you are giving those fluids. Don't just hang a liter bag and open it up and continue on with whatever you're doing, because before you know it, you got a whole lot of fluid in there that they didn't necessarily need. They probably do need fluid, but they don't need necessarily 500 or more. So pay attention to those fluids that you are giving.
Yeah, you're just going to turn them into a Michelin man and third space all that fluid, and your provider's going to look at you like you're crazy. So use your Biotrol sets, use your IV pumps, use your core safety measures.
Yeah, and it's something that we probably won't see right away, but they're going to be cussing you later in the hospital when they have to manage all of that fluid overload later. But pay attention to your fluids, pay attention to your tube depth, pay attention to all of this stuff, and just don't forget about it.
Yeah. So let's go ahead and jump into some pediatric medical here, and let's go ahead and talk about some common medical emergencies that we see a lot of. And this list is kind of exhaustive. This is something that I just kind of threw together. Isaac and I, collaborated on a little bit before this. And so one of the big things that we typically see in these pediatric patients is diabetes. It's undiagnosed or diagnosed, obstruction of the airway, asthma patients. Those are some of my most fun and scariest calls. And then you have your viral illnesses like your bronchiolitis, your croups, your epiglottitis, your pneumonias, your anaphylaxis. A lot of these come down to that we just don't know what we don't know yet. Do we know the kid has a diagnosis for asthma? Is this a first indicator? Do we know that the kid's allergic to bee stings, or is this the first time they've ever been stung? Thankfully for me, I'd never been stung, but found out I'm highly allergic, deathly allergic to yellow jackets, which is a really prominent bee in Idaho. And, I'm glad I found that out in my adults and not by, ER visit as a kid. So, it's just one of those things that, these common medical emergencies that we see may be the first time that the parent is even realizing that something's happening.
Yeah, one of the ones I want to talk about, and we're not going to go into signs and symptoms and all of the stuff of all of these different things, but these are just common medical emergencies we're going to see. One of them that we see frequently, and we have really, really sick kids, is that diabetes, because they don't know they have that diabetes, childhood onset diabetes. When it comes on and all of a sudden they're not producing insulin, and they get really, really sick. And a lot of times it takes a couple days before they show those skin signs and they show that altered mental status of being just super lethargic. And by the time we see those patients, man, are they sick. Some of the sickest kids I've ever taken care of are those new onset diabetes kids. Yeah. And they end up in the PICU for a pretty good amount of time because it takes so long to correct all of that acid-base balance and all of their electrolytes that they've gotten rid of and having to replace them. You can't replace them quickly. So these kids get really, really sick. So with that, when we have our medical patient, just like our doorway assessment we're going to do in that pediatric triangle that we are looking at right away for that first 10 seconds. Another thing that we really need to focus on when it comes to medical is just getting a really good history. What's their urine output been like? When's the last time they had a wet diaper? All of that kind of stuff. How are they feeding? When it comes to those kids with the diabetes, I mean, they probably have been thirsty for several days and they've been chugging water and they've been peeing it out twice as fast. So little things to think about with that one. But yeah, all of these are some major medical issues that we see that lead to really, really sick kids. And by the time that we see them again, with all the stuff that we've talked about, they're pretty far down that list of compensation. So they have that chance of decompensating very quickly. And that's why medical is just as bad as trauma when it comes to these kids and when we get to see them. So if parents bring them in super early, that's awesome, but it doesn't always happen that way.
Yeah. I just had a kid a couple weeks ago with a blood glucose of 1,205. It's not my highest record blood glucose, but it was a new onset thing. Parents didn't know. I mean, how could they have known until 3 days before? And, it's just one of those things that, they're very complicated because it's not just a blood sugar issue. I mean, like, you're treating a myriad of issues, from potassium, cardiac arrhythmias, all sorts of things. And it's just, these medical kids are very, very tricky sometimes. And that's why I love medical patients. It's one of my favorite categories of patients. And one of the things that leads down to, it's kind of the gateway, is the work of breathing tells the story a lot of the times. Because we're going to see things like nasal flaring. We're going to see those intercostal retractions, subclavicular. We talked about those a little bit. In the grunting. Grunting is scary. Like, if they're laying there listless and lethargic and grunting, I have an airway issue until proven otherwise, and I have a very, very sick kid. And then, mild, kind of work of breathing issues is kind of that tachypnea only. The moderate, we're seeing those retractions and nasal flaring, and that's severe. We're going to see that really bad fatigue, that decreased respiratory effort. So I kind of like to think about my respiratory storytelling as, our, the little cards that we use in mass casualty. I can't remember triage cards. Yeah. So I triage my pediatric patients, much like our mass casualties, of like, is this a red, yellow, or green? Like, what am I dealing with here? And you can base a lot of that off of respiratory drive and respiratory fatigue just by looking, listening, and feeling that chest wall cavity. And while you're there, listen to their heart, please, because you can get a lot of a good story without all of your fancy bells and whistles, because we've done it for years. But we also need to remember that those are very good things to put on your cardiac monitor, your blood pressure, your SpO2. Just make sure you're treating those trends and watching, treating. That comes down to evaluate, identify, intervene, right? EII. So we really need to make sure that we're following these patterns of promoting the health and wellness of these kids when it comes down to finding out what that story started and where we're at now.
Yep. And just like on the last part of that one, fatigue is last. Fatigue equals failure, right? We're not, you don't get fatigued, especially these pediatric patients, until the end. So they're teetering on the edge of that cliff. So we need to make sure, again, we recognize that stuff. Quiet does not equal better. I do not like quiet kids. I like loud kids that don't want anything to do with me. Perfect. Yep. We're going to get along just fine. If you want to cry the whole time, I love it. The one that's quiet, that's the sick kid. That's the scary kid. Anytime we have that decreased effort in anything with these kids, that should be the danger zone. Yeah. we should understand that. That's danger for pediatrics.
Yeah, I was just going to kind of tie that into, just think of your normal healthy kid. They go nonstop, right? They are nonstop all day. My child is nonstop all day. From the time she wakes up, she's basically an Austin Powers movie. She never stops. Like, goes from, dancing to breaking shelves. There's no in between, right? And so when these kids they peter out, there's a reason for it. And it's not always because I'm tired and want to go to bed. But let's go ahead and talk about this oxygenation and versus ventilation, because we've talked a little bit about vital signs. Let's tie it in a little bit better. SpO2 can lie, right? So just because they have a great SpO2 doesn't mean that there's not something underlying. You have to look at their respiratory drive, their rate, their, what is their chest wall doing, because they're going to hold on and then they're going to crash. So a normal SpO2 does not always, equate to adequate ventilation. That's going to change a little bit faster in these kids because of their, decreased physiologic reserve. But we really need to watch their ventilation status, because it may hold on to that SpO2, and then you're going to be playing catch up really, really fast.
Yep. And we just have to really pay attention to, like I said, that ventilation status, because as soon as that starts to fail with these guys, that CO2 is going to rise quickly, and it does it silently. So just because we place them on oxygen, which makes us feel better, and it's what they need, it doesn't mean that their CO2 isn't continuing to rise, because that respiratory effort is starting to drop. So we have to pay attention to that kind of stuff. We have to make sure that we don't need to assist these ventilations earlier than we think we do. When that respiratory effort goes down, that CO2 is going to go up. That acidosis is going to go up, which is going to go to that bradycardia. Again, all of that triangle that we've talked about. So we need to break that chain and maybe start assisting some of those ventilations a little bit earlier in these guys. So again, we don't have that rising CO2, that rising acidosis, and that impending cardiac arrest. So with our medical failure pattern, we've hit on this a lot: increased effort, fatigue, hypoxia, bradycardia, all the stuff we've talked about. All of these things, we need to pay attention to our patients, pay attention to those vital signs, not just the normal ones, but again, what's their effort, what's their attitude, how's their behavior. All of this stuff is showing us what's going on with our patient, and that's the biggest thing that we're taking away from this and why we're preaching on it so hard.
So with that, we're going to hit the last couple slides here and just tie in a little bit of NRP, because we've talked a lot about, the 28-day and older population. Let's bring it down just a little bit lower of age range. So remember that our neonates are typically defined as a patient less than 28 days old. So if they're 28 days and less, they're still considered a neonate. And we have to remember that there's a lot of main transitions that happen between, intrauterine growth to being born. They're transitioning from fetal circulation to neonatal circulation. They're closing all of those open holes, hopefully in their heart, transitioning into more of a normal cardiorespiratory system. And then if something happens, this is going to be a predominant, like we've talked about, airway oxygenation issue. So please, if you have not looked at your NRP card recently or reinserted your NRP, remember your Mr. SOPA techniques in your ability to manage a pediatric airway, because what we're going to talk about is, we need to, I'm going to move this slide really quick. Sorry. I don't know where I'm going with this.
You're good. Mr. SOPA, we need to.
Yeah, we really need to kind of hone those skills in, because that's where our big failure point as providers is going to come into. Like Isaac talked about earlier, is, sometimes it takes 3 sets of hands just to support, position, and squeeze a BVM. And if you are an EMS provider and not in a hospital and don't have the fancy NEOT things where you actually have to squeeze it and you don't get to just push a button and it, delivers that high flow positive pressure, you're really running resource limited. So try to, hone these neonate skills in a little bit and remember that Mr. SOPA is life when it comes down to these less than 28 days, because it's going to lead you down the path of when to start your CPR, what a good heart rate versus bad heart rate is, because we don't see a lot of these less than 28-day-old patients.
No, we really don't. We're usually in the hospital for that, and more NICUs and all of that, and they do a great job. But for us, it's, if you don't know what Mr. SOPA is, go look it up. Read it.
Yeah.
Understand it. Watch some videos on it, just that. But it is very, very good information. NRP, like Sam said, is one of his favorite classes. Same thing. I wish I actually had to restart it every year. I'm glad I don't, because I'm always busy. But it is a very, very good class to take, and something that I wish everyone would have to have.
Yeah. I wish it was required.
I wish it was too. Just like CPR, NRP is great. And some of the priorities that we understand and we get into with NRP is, especially having to deliver a baby, and you get these guys, is we want to warm, dry, and stimulate them. Airway positioning is huge, and positive pressure ventilation is one of the most important interventions, and it fixes most of these neonatal problems. It's not CPR. It's to get that heart rate up. Just like with our trauma patients, CPR isn't the answer. With neonates, same thing. We need to ventilate them well. And positive pressure ventilation is very, very important. Being able to understand how to do that. If you haven't practiced with a neo BVM or a very small BVM and how to actually ventilate, because there's a lot of times where like 2 fingers just barely squeezing the bag to get chest rise on the really little guys. And we got to just pay attention to that. It's a very, very difficult skill. Like I've said, BVM, I think on pediatric patients, the hardest skill that we actually have. So do some practice. Don't wait for all of a sudden you have that patient that you're trying to practice and learn on.
Yeah.
Make sure that you get out there, find somewhere to practice, talk to your educators, talk to your department, whatever it is. Make sure that you can do neonatal and pediatric BVM.
Yeah, and and this isn't a plug for NRP. We're not paid by NRP. We're not anything. No. It's just one of the most fundamental pediatric courses you can take. PALS is great, but PALS is great for 28 days and older. One of the things with NRP you also will see is that unlike our trauma resuscitation guidelines where, epi is a huge priority, like all of those other things that are fundamentally ground into our head, those are last priorities, the epi, the CPR, and all that, and all those things. So one of the things that it leads into is, just very basic things. Neonatal bradycardia. They're less than 28 days old. If they have a heart rate less than 100, that's bad. Okay. So we need to get their airway problem fixed. We need to get them oxygenating. We need to get their SpO2 on their right wrist, okay, because that is their preductal SpO2 that's going to show you their the truest oxygen concentration that you can have. And then if their heart rate is less than 60, you're going to start compressions after adequate ventilation. You need to give them a fighting chance before you start squeezing the heck out of their heart. And that is the hardest time to wait, because you want it to happen immediately. Remember, oxygenation takes a little bit of time, because not only do we have to have a good diffusion gradient, we'll go into some, little bit of in-depth A&P here. We have to have that diffusion gradient, so higher oxygen outside of the lungs going in through the alveolar membrane. You have to have the circulation and things like that. But I lost my train of thought there.
Ventilation.
Yeah. Important. Yeah, ventilation's important. My brain farted. What was I going into?
You had gradient.
Yep. Holy shit, I've never had a brain fart this bad. You can cut that out. Maybe. So we need to give these kids that fighting chance before we start doing these compressions. We're going to go into a little bit of a physiology lesson here, because remember, with these BVMs, we have to have that higher concentration of oxygen outside of the lungs to diffuse through the alveolar membrane. It has to have oxygen carrying capacity within the body. So we need to give these kids that fighting chance, because hypoxia isn't fixed immediately. Because what we're looking at is we're trying to play catch up. We have to saturate those hemoglobin. We have to give the body the chance, because we're going from, hypoxemia to hypoxia. And remember, hypoxia is the late stage. Hypoxemia is the first stage in the cascade effect there. So we need to treat their hypoxemia, allow that nice oxygenated blood to make it through the coronary arteries, to make it through the circulatory system, to allow the heart to restore some, I'm getting some good oxygen. I'm going to start beating faster. I'm not in, a preservation mode, to say. So we got to give this a little bit of time. And that's where that wait is so hard, because people and caregivers want instant gratification frequently. And so just give that, that hyperoxygenation period a little bit of time to watch that trending heart rate come back up. But if it stays low per the NRP guidelines, that's when we start our chest compressions and access and all the other things that come along with it.
Yep, and big point is just, even in neonates, especially in neonates, it's respiratory first. So I know we've said it a million times. We'll say it probably 10 more, if not more than that. Respiratory failure first. We got to treat that hypoxemia, treat that hypoxia, oxygen, ventilations. That stuff is important.
Okay, so we're going to move on to the compensation to death. We have this and one last little section to go over. A lot of this stuff should hopefully be reviewed, because one of the things that we're going to talk about here is the save happens here. This is because typically this is where you're going to see these sickest kids. So this is the before the monitor tells you that they're sick side of things. This is your doorway assessment. So recognizing that early respiratory distress, recognizing early mental status change, and recognizing pre-hypotension physiology, okay? So that is that whole triangle that we've talked about, and that's where this save truly happens, because we're trying to get these kids from compensated shock and keeping them out of further, variations of shock. So let's start with compensated shock, just a quick little overview.
Yep, I know we've talked about it, but remember, these kids, they compensate well, and then they have that tachycardia, that tachypnea, and that normal blood pressure. Because they have that high heart rate and that high respiratory rate, they compensate really well until their body wears out. So that tachycardia, again, we're paying attention to that. What should be our normal ranges? And why is this kid tachycardic when he's just sitting here? Besides the fact that he's in pain, if it is trauma, we have to think beyond pain and simple things that cause a high heart rate, and we have to pay attention and understand that they're probably in some sort of compensated shock. And that early recognition, like he said, is just going to keep us from the uncompensated shock, right? Remember that late sign of hypotension, super late, just like our skin signs on these pediatric patients. It is a super late sign. They are already in uncompensated shock, and we have got a lot of work to do. So all the uncompensated shock, again, the hypotension, that super altered mental status, weak pulses, pale skin, the skin signs, all of that is uncompensated shock. So
you just did 44, right?
Yeah.
Okay. So let's just go brief reminder of our terminal events if they're untreated, okay? We're getting to the point of this lecture where we're going to start harping on the things that we need to change as clinicians, okay? So if left untreated, hypoxia, acidosis, bradycardia leads to cardiac arrest. We need to break that chain. We need to treat them well, and we need to be proactive in so many different ways. And that's why the window of opportunity is so small in these kids, because the save has to happen early. It needs to happen before blood pressure drops. It needs to happen before, the respiratory issue worsens or even really gets addressed. And then it needs to happen before the patient is, needing that full, true resuscitation. We have to catch these things early, or else that window of opportunity is going to open and they're going to crash on you faster than you can imagine.
Yep. And I'm going to talk to my advanced providers here. From paramedics, nurses, critical care nurses, doctors, anybody, remember bradycardia. The reason they're bradycardic, it's probably not their heart. Bradycardia is because of hypoxia, right? Bradycardia equals peri-arrest. They are circling the drain hard. They're getting towards the end when they're bradycardic. So we need to treat with oxygen, ventilation. This is not a sick adult patient who's going to get atropine because they have some cardiac issue.
Yeah.
This is hypoxia, right? We want to treat early. And that's, just the theme. Oxygen, man. Get these kids ventilating well because that's what is usually the problem.
Yeah. And with that, we're going to go into some of the touchy-feely things here and the final thoughts. And so one of the things that I really want you guys to take home today is what are the changes I'm going to make today? And some of the big ones here, we got 5 of them. You can choose some of them. You don't have to do them all in one day. You don't have to do it these are the big indicators. And the first one here is I will assess work of breathing before monitors. I need to get that good patient view outside of the box. I walk in, oh my gosh, they're breathing 60 times a minute. Look at those retractions. Great. Put your monitor on as you're doing that. You can do these tasks simultaneously, but assess that work of breathing, please.
Yeah, the next one is I will treat behavior changes as early hypoxia. Remember, behavior changes in children, in our pediatric patient, is the same thing as an altered mental status in your adult patient. That is a vital sign. Something that I want to pay attention to is how that kid is acting. Any change in their behavior is a change in basically their entire status, and especially with hypoxia. So with their oxygenation and their metabolic demand, that's altered mental status for them. Changes in behavior is something that I'm going to treat early and think about as being hypoxia.
Then the next one here, I'm going to emphasize this a lot. I will not trust normal vital signs in a sick child, period. If they fall out of that PAT triangle and you determine they are sick, you need to watch for their vital sign abnormalities. No basic vital signs. Get a card. I don't know. I don't really care how you do it, but understand the normal physiologic vital sign ranges for your age group that you're treating at that time. Because if you don't understand those, then we have a kind of a lapse in what we're going to be able to do. So please don't trust the normal vital signs in a kid because they are going to drop faster than you can imagine. They're going to go into compensated, they're going to go uncompensated, and then they're going to fall off that cliff faster than you can imagine.
Yep, next change is I will intervene before hypotension. I never want to wait for hypotension. I can personally had a call not too long ago where we gave blood immediately. We walked in, we saw that kid, we knew everything that had happened, and we gave blood right away, started that resuscitation process for this kid, and then got questioned about it later. It's like, well, why would you give blood if their vital signs are normal? Well, turns out we ended up giving a whole lot of blood to that kid later on, and I was shocked that the provider even asked me that, but it's because I wasn't going to wait for that hypotension and that irreversible shock that was impending to give blood, to give those fluids, intervene before they get hypotensive. That's an insanely late sign. Do it.
Then the last one here, I will treat bradycardia as a respiratory emergency. We've whipped that horse enough through this, so please treat bradycardia as a respiratory emergency unless they got into a whole bottle of beta blockers, okay? So please watch out for that bradycardia. And then some of the things, remember, trauma versus medical, they're going to have similar physiology, similar failure. The big thing with trauma, they're going to have that incident of injury on top of it.
Don't forget to trend those numbers. It's not just one set of vitals that we're worried about. We need to pay attention, and we need to trend that stuff, and that's going to let us know how we're doing, how the patient's doing, and what we can do to make things better. Respiratory effort matters. Again, we've beat that down in this lecture. And then early interventions, they save lives. We're not seeing these kids right when they're getting sick, just like we talked about in the beginning. There's so many things that cause us to get to these patients late. So we need to do early interventions. It's going to save lives and get that ball rolling, turn these kids around.
Yep. And the final thing here is I'm just going to say thank you guys for listening in. The big things is you don't need to be fearless. You need to be prepared, okay? It's okay to have fear in these calls. We want you to, have these emotions and feel the ways that you do, but you also need to be prepared at the same time. That's why we harp so much on preparedness, and because that leads you into a non-reactive state. You're prepared, non-reactive, unless you need to be reactive in the moment. But on that, when you understand the physiology, pediatric calls, they can be a little less scary and start to be a little bit more manageable. So really take that to heart. If you understand the physiology, pediatric calls stop being scary and start being manageable. The more you understand, the more you're able to manage these patients confidently. And for that is what I got. I've talked enough. I'll let Isaac finish her off.
Yep. And with that, you don't need to be fearless. Be prepared. It's that same thing with those interventions. I know it's scary. It sucks having to start an IV or an IO on a kid, or suction the heck out of them because it's going to make them mad. But it's stuff that we have to do. So whatever you need to do to get over that fear, you just got to do it. And it's okay. I get scared pediatric patients all the time. I am not fearless, but I know what I'm going to have to do, so I'm going to do it, and you need to be the same way. Like I said, pediatric calls will always be scary, and that is okay. But understand this stuff. Make sure you're ready for it, like Sam said, so you don't have to all of a sudden be reactive and do something for the very first time. But just be prepared. Think about all of these things that we've talked about today, and do a great job. Early interventions, treat hypoxia, and we'll see you guys next time.
Adios.